You probably climbed into bed last night without thinking twice about it, rolled into your usual position, closed your eyes, and drifted off. But while you were unconscious, something was happening inside your blood vessels that you never felt, never noticed, and were never warned about. One common sleeping pattern compresses a major vein in your body every single night. The damage builds so gradually that by the time any symptom appears, the injury is already done. In the next few minutes, I am going to walk you through which habit cardiologists are now flagging as a serious concern, and exactly how to correct it before tonight. Quick orientation, because I want to be honest with you about what comes next. Some of what I am sharing sits on very strong human evidence, randomized trials, large cohort studies, physiological measurements on thousands of subjects. Some of it sits at the edge of what has been formally studied, supported by pilot work, plus consistent clinical observation. I will be transparent about which is which. None of it replaces a clinical evaluation by your own physician. None of it is intended to diagnose anyone watching. The case descriptions you are about to hear are illustrative composites, anonymized patterns drawn from clinical practice, not named patients. I'm Dr. Richard. I have spent years in clinical cardiology with a focus on overnight cardiovascular events. But what follows is educational, not personalized medical advice. Please bring any persistent symptoms to your own clinician. Before we go further, drop a comment with your age and tell me whether you sleep on your back, your left side, your right side, or curled tightly. Within 60 seconds, I will tell you which category put you on this list. If you are over 55, what is coming is no longer optional, a note on timing. Nearly a third of all ischemic strokes actually occur in the morning hours, typically clustered between roughly 6 a.m. and noon. That is not me being dramatic. It is the consistent finding across multiple meta-analyses, including patient population studies like the Auckland Regional Stroke Registry and broader reviews of stroke onset timing. The mechanism is the early morning blood pressure surge, a rise in platelet aggregation, and the abrupt reactivation of the sympathetic nervous system as your body crosses the sleep-wake boundary. The position you choose during the deep hours preceding that surge directly shapes how your cardiovascular system arrives at it. We are counting down from 5 to 1, concerning habits first, dangerous habits last. Then 2 specific positions, backed by clinical research, that can protect your brain and your heart, starting tonight. Number 5. Lying completely flat with no elevation. Number 5 is lying completely flat on your back with no head elevation at all. This one catches people off guard because flat supine feels like the healthiest position, spine aligned, weight distributed evenly. Plenty of wellness content recommends it. Your cardiovascular system tells a different story after 60. When the body is perfectly horizontal for 7 or 8 hours, blood migrates toward the head. Gravity is no longer assisting venous drainage from the cranial vault. It is encouraging accumulation. In a younger person with elastic, responsive vessels, the body compensates without issue. As arteries stiffen with age, that compensation grows weaker. The small vessels feeding the brain become more fragile. When blood pools inside the skull for an extended period, intracranial pressure climbs. That throbbing headache you sometimes wake up with at 3 a.m. is not random. That is pressure accumulating inside the cranial vault because excess blood volume is not draining efficiently back toward your heart. Head-of-bed elevation has been studied for decades in neurosurgical practice. Work going back to the head injury physiology literature. The foundational paper is generally credited to Durward and colleagues in the early 20th century and has been replicated in modern critical care. Established that elevating the head of the bed to approximately 30 degrees measurably reduces intracranial pressure compared with flat supine, while still maintaining adequate cerebral perfusion pressure. That mechanism does not apply only to trauma. It applies to any older adult whose vascular system is operating on reduced reserve. A patient wakes up dizzy every morning. They swing their legs off the bed too quickly, stand up, and the room tilts sideways. They blame age. They blame dehydration. What may actually have happened is that blood flow regulation failed through 7 hours of flat positioning, and the brain is playing catch-up the moment the patient goes vertical. A single pillow under the head alone won't work here. Bending only at the neck recreates an exact problem we are about to discuss in number 4. The full correction comes at the end. Number 4, stacking 3 or 4 pillows. Number 4 is using a tower of 3 or 4 pillows under your head. People do this for genuine reasons. Acid reflux, chronic congestion, sinus pressure. Some modest elevation really is beneficial, But excessive stacking creates a problem almost no one discusses. When you pile that many pillows under your skull, your neck bends forward at a steep sustained angle. Not a gentle curve, but a dramatic forward flexion. Running along both sides of your cervical spine are the vertebral arteries. These vessels supply the brainstem and the cerebellum, regions that govern balance, motor coordination, and the basic ability to remain conscious. When the neck is forced into sustained forward flexion, those arteries can be mechanically narrowed. You will not feel it happening. There is no sharp pain with this, no tingling alarm. But oxygen delivery to the brainstem and cerebellum can quietly decrease week after week. That stiffness at the base of your skull every morning, paired with a dull ache, is not just muscle tension from sleeping ergonomics. It can be reduced vascular flow through vessels the body fully relies on to keep you upright and conscious. I want to be honest about the evidence here. The cervical manipulation literature has documented that head and neck positioning influences vertebral artery flow, with rotation already well established as a clinical risk factor. The sustained forward flexion picture from stacked pillows is supported by anatomical reasoning and consistent clinical observation, though the controlled trial data on it specifically is thinner than I would like. Replacing the pillow tower with a single, properly contoured memory foam cervical pillow is a reasonable first-line solution with no meaningful downside. A patient comes in with chronic morning headaches and neck stiffness that has gone on for years. They've cycled through pain medication, physical therapy, and 3 different mattresses. Then they replace the pillow tower with one properly contoured memory foam cervical pillow. Within 10 days, the headaches largely disappear. 1 pillow. That was the entire intervention. Number 3. The tightly curled fetal. Position number 3 is the tightly curled fetal position. Knees pulled up against the chest, chin tucked down, torso bent forward. It feels instinctively protective. It is also, physiologically, one of the more restrictive positions. Your cardiovascular and respiratory systems can occupy for 7 continuous hours. The respiratory effect is the more immediate concern. When the torso is bent forward and knees are drawn firmly against the chest, the rib cage cannot fully expand. Every breath in that posture is shallower than it should be. Tidal volume, the actual amount of air moved with each breath, drops measurably. Respiratory physiology literature has consistently shown that body positions involving significant spinal flexion reduce lung compliance and tidal volume compared with extended or neutral postures. You know that sensation when you first wake up and cannot seem to draw a satisfying deep breath, as if the chest is partially locked. That is your lungs having spent the entire night in a restricted state. When tidal volume drops even modestly, blood oxygen saturation follows. For someone with early-stage cardiovascular disease or undiagnosed chronic obstructive disease, this matters substantially. For healthy lungs, the body has enough reserve to compensate. For compromised lungs, hours of cuffed ventilation place real load on both heart and brain. A vascular problem compounds this. The neck and upper back remain in constant flexion through the night. The muscles along the cervical spine stay contracted. Small vessels around the base of the skull get squeezed. A patient wakes up feeling foggy, with an ache behind the eyes, slightly unsteady when they first stand. They assume they slept badly. What may have happened is that their lungs operated at reduced tidal volume, and the brain operated on slightly compromised oxygen supply for the entire night, and it is still recovering when the alarm goes off. The fix is straightforward. Stop curling into a tight ball. Sleep with the legs extended, knees soft. A pillow between the knees if you need hip support. The postural change is mild. The reported improvement in morning breathing capacity is consistent. Number 2. Left side sleeping for people with a noun heart. History number 2 is reserved for a specific group. If you have a known diagnosis of atrial fibrillation, particularly paroxysmal atrial fibrillation, or a documented history of heart failure, the standard sleep on your left side advice may be the wrong advice for you. This sounds oddly specific. Stay with me. Gottlieb and colleagues at Amsterdam UMC, in a study published in Frontiers in Physiology in 2021, examined how sleeping body position affects atrial dimensions and the epidemiology of nocturnal arrhythmia episodes in patients who experience paroxysmal atrial fibrillation. Their findings were both surprising and a little unsettling. The left lateral body position was associated with measurably larger left atrial geometry in a subset of those patients, and the patients whose nocturnal AF episodes did occur did so predominantly during the left lateral sleep posture, in simpler terms. When you lie on your left side for hours, the geometry of the heart and the orientation of the pulmonary veins shift slightly within the chest cavity. For most people, that shift is meaningless. For someone prone to atrial fibrillation, the change appears to be enough to trigger an episode that surfaces as a racing heart when they wake. For heart failure patients separately, the literature is consistent on a different related point. Patients with congestive heart failure frequently show poor tolerance of the flat supine position because of orthopnea, that breathless feeling when lying flat, and in practice often self-select either head elevated or right lateral sleeping postures to relieve pulmonary congestion. The classic teaching in heart failure is to elevate the head of the bed, not to lie flat on either side without that support, the combined picture. And I want this to be very clear. If you carry a known diagnosis of atrial fibrillation, particularly paroxysmal AF, sleep on your right side or on your back with the head of your bed elevated. If you have heart failure with orthopnea, sleep elevated, not flat on either side, and discuss left lateral tolerance with your cardiologist specifically. The blanket sleep on your left side advice that circulates online was never designed for cardiac patients. It is designed for the general population. You are not the general population if you have these diagnoses. For the vast majority of people over 60 without a known heart condition, the recommendations we are about to cover do apply to you. But first, number 1. Because number 1 combines multiple cardiovascular risks into a single nightly routine, bed within 2 hours of a-log dinner, or alcohol. Number 1 is going to bed within 2 hours of finishing a large dinner or having alcohol. I know this one hits close to home. Evening meals with family, a glass of wine to unwind, it is woven into daily life. From a cardiovascular and cerebrovascular standpoint, this is the most dangerous pattern on the entire list. Here is the mechanism. When you eat a substantial meal, your body diverts a significant volume of blood toward the gastrointestinal tract to support digestion. That redistribution is normal and temporary. It also means less blood is available for your brain and heart during the hours immediately following the meal. In a younger person with healthy vessel elasticity, the body manages this redistribution smoothly. In an older adult with reduced cardiac reserve, the supply deficit to the brain can trigger dizziness, lightheadedness, or prosyncope during the night itself. Now layer alcohol on top. Alcohol initially acts as a vasodilator. It opens peripheral vessels and causes a measurable drop in blood pressure. For flexible vessels, that feels like relaxation. For an older adult with stiffened arterial walls and atherosclerotic plaque, the sudden pressure drop is followed by a compensatory spike and subsequent crashes. These volatile oscillations stress vessel walls. They also create conditions where small clot fragments can lodge in places they have no business lodging. All of this is happening while you are unconscious and unable to respond. The American Heart Association has published extensively on the relationship between alcohol consumption and disrupted nighttime blood pressure patterns. Even moderate drinking close to bedtime blunts the natural nocturnal blood pressure dip that healthy sleep is supposed to deliver. When that protective dip fails to occur, overnight cardiovascular strain increases substantially across both heart and cerebrovascular systems, a scenario playing out in real time. He finishes a large pasta dinner at 7:30 p.m., 2 glasses of wine, bed at 9:45. At 1 in the morning, he bolts awake with a pounding headache, his heart hammering, the sheets damp. He assumes he had a nightmare. He did not have a nightmare. That was his circulation, scrambling to stabilize wildly fluctuating blood pressure while his brain demanded more oxygen than his compromised vessels could deliver. Picture what such an episode leaves behind over months and years. Small vessel injury, microhemorrhages he will never feel, silent cerebral infarcts that chip away at cognitive function without producing dramatic symptoms. Until one night, the event is no longer silent. If you take nothing else from this video, change this habit. Finish your last meal at least 3 hours before lying down, ideally 4. If you drink alcohol, allow 4 or 5 hours of clearance before bed. After dinner, walk for 15 minutes. Gentle movement around the block, around the living room. That alone moves blood back into general circulation and reduces overnight strain. Those are the 5 habits to eliminate. Now, here is what you should be doing instead. Recommendation 1. Left lateral sleeping with proper support for most healthy adults without diagnosed cardiac conditions. The first recommended position is left side sleeping, with a setup that actually keeps you there. Your heart sits slightly left of center in your chest cavity. When you sleep on your left side, Gravity works with the natural architecture of your cardiovascular system rather than against it. Blood returns to the heart more easily. Your heart generates less effort per beat. Your brain receives more consistent oxygen delivery through the night. That is the basic cardiac physiology. Here is the part that changes the entire conversation about long-term brain health. In the early 2010s, the research group led by Macon Nedergaard at the University of Rochester identified a system they called the glymphatic pathway, the brain's overnight cleaning infrastructure. During deep sleep, cerebrospinal fluid pulses through brain tissue and flushes out metabolic waste products, including amyloid beta and tau. Those are the proteins whose accumulation in the brain is one of the hallmark features of Alzheimer's disease. The original work was done in mice. Human imaging work has continued to confirm that glymphatic activity operates in the human brain during sleep. Most notably a 2021 study by Lee and colleagues published in Radiology, which used contrast-enhanced T1 mapping to visualize sleep-dependent solute clearance directly in humans. Related rodent work by Hedok Lee and colleagues in the Nedergaard lab demonstrated that lateral body position is the dominant natural sleep posture in mammals, and that glymphatic clearance efficiency improves measurably in the lateral posture compared with the supine posture. A 2023 study by Gedek and colleagues using polysomnography and 3T MRI confirmed that the lateral position is the dominant human sleep position in clinical samples and discussed the implications for glymphatic research going forward. Every single day, your brain generates those waste proteins as a byproduct of normal function. In a healthy brain, the glymphatic system clears them out every night. Across decades, the consistency of that nightly clearance matters as much as the volume of debris generated. Left-side sleeping is not the whole answer, but it is one of the few practical levers that an ordinary person can actually pull on every night without a prescription. There is a practical bonus. The anatomy of the stomach and the esophageal junction means that left-side sleeping keeps gastric acid where it belongs. You wake up without the burning chest sensation that drives so many people to stack pillows in the first place. Most adults are not naturally left-side sleepers. The realistic adjustment, a full-length body pillow. Position it in front of you, hugging it against your chest and abdomen. The bulk prevents you from rolling onto your back through the night. Place a smaller pillow between your knees to keep your spine neutral and your hips from collapsing forward. Spend the first week consciously rolling back to your left side if you wake at 3 a.m. You will. That is completely normal. But the body pillow cuts the involuntary supine time dramatically. The objective is not perfection. The objective is spending the majority of your sleep hours in a protective position rather than a harmful one. One important caveat, which I will repeat because it is important. If you have diagnosed atrial fibrillation or documented heart failure, we just covered why right side or elevated back sleeping may be safer for your specific profile. Choose based on the cardiovascular history your own physician has already mapped out. Do not blanket apply recommendations designed for healthy adults to yourself if you are not one. Recommendation 2. Head elevated back sleeping, the second recommended position, works exceptionally well for a different group. Back sleeping with gentle upper body elevation. Not flat, not sitting upright. A gradual incline that raises the torso by 15 to 30 degrees. You can achieve this with a foam wedge designed for that purpose, an adjustable bed frame, or carefully arranged firm cushions. The critical detail is that your entire upper body elevates together, not just your head. Bending only at the neck recreates the exact vertebral artery concern we covered in number 4. This position works for 3 specific reasons. First, blood returns more efficiently from your lower body to your heart. If you deal with swollen ankles at the end of the day or visible varicose veins, this position assists the cardiovascular system during the hours when it should be recovering, not struggling. Second, intracranial pressure decreases. For anyone with fragile cerebral vessels, head-elevated sleeping reduces the risk of small vessel injury overnight. These microhemorrhages rarely cause dramatic symptoms, but they accumulate across years and contribute to vascular cognitive impairment later in life. Third, your airway stays more open. If you have mild obstructive sleep apnea, chronic nasal congestion, or sinus inflammation, this elevation reduces tissue collapse in the throat, decreases snoring, and improves oxygen delivery to your brain through the full sleep cycle. One elegant detail most people miss. Place a small pillow or bolster under your knees. This preserves the natural lumbar curve of your spine, The combination of gentle upper body elevation with supported knee flexion creates what is called a neutral gravity posture. Mechanical pressure distributes evenly across the body. Strain on joints and vessels is minimized simultaneously. Position selection by profile. Left side sleeping is the default for most healthy adults over 60, particularly those without known cardiac conditions. Head elevated back sleeping is the better choice for people with sleep apnea risk, reflux, swollen ankles, or fragile cerebral vessels. Right side sleeping or elevated back sleeping is the safer choice for people with diagnosed heart failure. And right side sleeping is the literature-supported choice for people with diagnosed atrial fibrillation, particularly paroxysmal AF. The point is not to memorize a rigid rule. The point is to understand the mechanism and choose correctly for the cardiovascular profile you already know. Had to expand in the first 14 days practical reality check, because behavior change in sleep is harder than behavior change anywhere else. You will not consciously control your sleeping posture. The body moves through the night, often dozens of times. The objective is to bias the majority of your sleep hours toward a protective position, not to lock yourself into one. Practical setup for left side sleeping. Place a body pillow on your left side, hug it. Place a second pillow between your knees. Sleep in this configuration for 21 nights. After that period, most people report a noticeable shift in their default sleeping posture, even before fully waking. Practical setup for elevated back sleeping. Purchase a foam wedge with a 15 to 30 degree incline. Place a thin pillow on top for your head, oriented so that the cervical curve remains neutral. Place a small bolster under the knees. Sleep in this configuration for the same 21 nights. Common early side effects worth noting. A few people report vivid dreams in the first week. A few people report waking once per night to readjust. Both patterns typically fade by night 10. If morning dizziness persists past the second week, that is a signal worth bringing to your physician. It can indicate that an underlying vestibular or blood pressure issue is more active than the position change alone can resolve. What success typically looks like by week 3. Morning headaches that were previously common are reduced in frequency or gone. The sensation of being foggy on waking is replaced by a clearer transition into the day. Blood pressure measurements taken in the first 30 minutes after waking trend lower than they did during the previous month. A small change that compounds across years. The bedroom itself matters. To even the perfect sleeping position cannot fully compensate for an environment working against your recovery. Temperature is the first variable. Keep your sleeping room between 64 and 68 degrees Fahrenheit. A cool environment triggers the natural drop in core body temperature that initiates deeper sleep stages. It also reduces nighttime blood pressure naturally, taking strain off cerebral vessels during the most vulnerable hours of the night. A warm room keeps you cycling through lighter sleep phases where your heart rate stays elevated. Next, eliminate blue light from screens after 9 p.m. The blue wavelengths from phones, tablets, laptops, and bright overhead lighting suppress melatonin production. That delays the onset of the deep sleep stages, where most of the overnight cardiovascular and waist clearance work happens. Third, use proper cervical support. A single memory foam pillow with a contoured cervical ridge supports your neck's natural curve without forcing your head into angles that compromise blood vessels. This one simple change resolves chronic morning headaches in a remarkable number of patients. Finally, address overnight noise. Sounds that never fully wake you still snatch your nervous system out of deep sleep. Your heart rate spikes. Cortisol floods your bloodstream. The vascular system absorbs each of those microstress responses. You will not remember them in the morning, but your blood vessels register every one. A white noise machine or quality earplugs create the consistent sound environment the autonomic nervous system needs to remain in deep recovery. If you want to go further, track what is actually happening at night. An overnight pulse oximeter, the small clip that sits on your finger, monitors blood oxygen levels hour by hour. If your saturation repeatedly drops below 92%, that is a meaningful clinical finding worth discussing with your physician. A sleep tracking ring or smartwatch can measure heart rate variability overnight. Low variability signals that the nervous system is under strain and inflammatory markers are likely elevated. I want to be balanced here. Tracking supplements clinical care. It does not replace it. If you notice persistent patterns, bring the data to a qualified healthcare provider. Wobby your physician probably. Never mention this sleep positioning does not have a billing code. There is no lab test for it. No imaging study evaluates how you lie in bed. In a packed 15-minute appointment, focused on reviewing blood work and adjusting prescriptions, the conversation about how you position your body during sleep simply never happens. But the underlying vascular physiology is real. Sleep is when cardiovascular recovery, cerebral waste clearance, and blood pressure regulation either happen as designed or do not, for anyone over 55, for anyone managing hypertension, for anyone with a family history of stroke. These overnight variables become clinically meaningful across the years. Here is the part that should genuinely encourage you. You do not need a prescription for any of this. You do not need expensive equipment. You need awareness and a few targeted adjustments to how you sleep. Pick one change from what we covered. Maybe you switch to left side sleeping with a body pillow tonight. Maybe you stop eating within 3 hours of bed. Maybe you retire the pillow tower. Start with one change. Commit to it for 7 days. Pay attention to how you feel each morning. Tell me in the comments which change you are making first. Your answer will help someone else in this audience recognize a pattern they have been living with for years without connecting it to how they sleep. If this video gave you information you have genuinely not heard before, share it with someone over 60, someone managing blood pressure, someone waking at 3 a.m. with symptoms they cannot explain. And while you are here, subscribe. Next week, I am releasing a video on 4 specific foods that peer-reviewed clinical trials have linked to measurable reductions in stroke incidence. Not vague dietary advice, specific foods, specific quantities, backed by specific research. You likely have 2 of them in your kitchen right now, but you may be consuming them at the wrong time of day for the protective effect to work. Hit subscribe and turn on notifications, because what you learn today builds directly into what I am covering next. Leave smart, protect your brain. I will see you in the next one.